previous Give Me Five, we went ahead and touched on the basics of belly buttons. Meaning you've got a little baby who pops out, whether it's in the back of the rig, the ER, the hallway, otherwise known as anywhere outside of labor and delivery. And we looked at the whole idea of if the baby is sick, how the heck do I put an IV into the belly button? So now what we'd like to do in this one is take that one step further and touch on various options that you can use in a pinch to actually put a catheter into the belly button so that you can get blood. You can send it off to the lab. You can shove in your fluids, epi, antibiotics, etc. So now with that, the first idea that comes into play is, well, what the heck do I put in the hole? And that's important because in many paramedic and ER textbooks, some of y'all remember they teach you can take an IV catheter. And once you find the correct hole, you can very easily thread it into the hole. And as you're gently threading it in, you suck back on the syringe. And if you get blood back, you're ready. Just like starting an IV, you get a flash, you're happy. However, as you noticed, when we threaded this in and I'm sucking back on the syringe, I don't get anything back. That's important. Because the book says it works, real life says, yeah, maybe not so much. Because depending on how much cord you've got and how much baby fat you've got, your IV catheter honestly may not be long enough to actually hit the blood, meaning inside of the baby, like you're hoping for. But when you do this technique, can you try it? Sure. Does it work? Sometimes yes, sometimes no. But what's important is you notice right here we have a stopcock. And I highly recommend, if you're going to do anything involving a belly button, put a stopcock on first. And the rationale is, once you're in, think about it, now you've got blood just pouring all over the place, and if you don't have a stopcock, you have nothing to act as a stopper. So with that, before you thread it in, put a stopcock on there first. So that way, if you don't want it to bleed, just turn the stopcock off. And once it's in place, then think about it. You can immediately shove your fluids, your drugs, your antibiotics directly into the catheter. And it's just a whole lot closer to the baby. So if the IV catheter trick is highly overrated, some of y'all remember from a previous Give Me Five, especially on the hospital side, what they really recommend is a belly button catheter. And the reason that belly button catheters work so well is, number one, they're a foot long. And number two, even in preemies, they're small enough to easily thread into the big hole. And with sterile gloves, one person is going to hold the cord so that you can find the hole. And once you find the hole, as you gently thread the catheter in, you're sucking back on the syringe. Because once you're able to easily get blood back, you've hit where you're trying to hit. Don't go any further because you don't want to accidentally go into the liver or some other organ. All you're trying to do is get a flash of blood. And then in the nursery, they can do x-ray, ultrasounds, etc. to figure out where do I want this to be. So in real life, what's recommended is a belly button catheter. Now, that is your choice. In real life, though, if you don't have a belly button catheter, right, because the IV catheter probably is not going to be long enough, can you put an intraosseous line? It's called absolutely. Is the nursery going to have a seizure? Absolutely. But it absolutely works until the nursery can go ahead and get you something else. So belly button catheters made to go into belly buttons, you've got them, great, please use them. However, just a quick reminder as to things that are not recommended. First of which is for many years back. We used to teach that in a pinch, you could take a small NG tube, otherwise known as a feeding tube. And if you notice, it looks just like a belly button catheter did. And what was really cool is the tiny ones would actually have a stopcock be able to fit directly to it. And you could thread it in and it worked wonderful. And we did this in a pinch for many, many years. That's changed. And the reason it's changed is all things safety in healthcare. And they had issues with people putting stuff into tubes that shouldn't be going into tubes. Therefore, they changed the end of all NG tubes. And now they all are much wider, and you notice a stopcock or a syringe does not fit into it. That's important. Because if it doesn't fit, that's a clue you probably shouldn't do it. So they used to do this, worked great. For several years, it's not the case anymore, meaning don't bother. Now, other things, reminder, that are not recommended, that I've heard of that is not recommended. Number one, if you take a very tiny baby endotracheal tube, and if you rip the top of it off, people will say, you know what, that I can take a stopcock and thread it in there. You know what, that's absolutely true. Problem is, number one, it's too big. And number two, more importantly, it's a whole lot stiffer than your belly button catheter is. So, as you can imagine, MacGyvering it or winging it, in this case, is not recommended. The last one that I never would have thought of, but somebody brought up in a class because they heard about it, was to take a baby suction catheter. And a baby suction catheter, I mean, it's small enough to easily thread into the hole. The problem is, you notice, number one, that it doesn't stay put. And if you try to twist it on and it doesn't stay put, that's a clue that you're doing something wrong. Number two, even if you were to hold it or duct tape it into place, when you start pushing fluids in or sucking blood out, it's going to come right out the hole. So again, if it doesn't fit, it's leaking all over the place, that's a clue you probably shouldn't be doing that. So if you need an intraosseous line, great, use your intraosseous line. If your IV catheter trick works, wonderful, great. Otherwise, especially in the hospital or on transport, your umbilical catheter, meaning it's meant to go into the umbilical vein, is where it's at.
Scenarios in Seconds was designed to be a simple and effective way to regularly train for pediatric emergencies. A Navy SEAL said it best: under pressure, we don't rise to the occasion, we sink to the level of our training. Ultimately, your next PEDS patient could be your worst PEDS patient, and we don't want you to just get ready, we want you to stay ready. And Scenarios in Seconds was designed to help you do just that.